For those that don't know me, my name is James Symons. I'm a urologist here. I work at St Vincent's as well. I've got rooms here, rooms at Eastwood and rooms in St Vincent's. I also travel out to the country and do a cancer outreach clinic regularly in Wagga Wagga, where I had the fortune of doing some of my training as well. So we've got a strong affiliation with the country going on for the last decade or so. Just this weekend, in fact this afternoon, I've flown back from the Asia Pacific Prostate Cancer Conference, which is now in its 20th year. So the purpose of tonight's talk really is to give a synopsis of everything that is current as of today. So the slides have been made up until early hours of last night, so it's very fresh, but you'll have to forgive me if they're a little bit disorganised because they've been a work in process. The reason why we're here really is because of, most of you will have been touched by prostate cancer in some way or another. Over 200,000 men in Australia will be diagnosed or living with prostate cancer in 2019. And at present point in time, it accounts for about 3,000 deaths annually. So the Asia Pacific Prostate Cancer Conference is a very large annual conference held in Melbourne normally. In recent years, it's gone up to Brisbane as well. Very wide personalities across the world that come to it. We've even had a little celebrity giving applause for our 20th year this year. The focus on this year's conference was really to look at, is cure possible for prostate cancer across all domains of prostate cancer, but also work out, is cure actually necessary? And then for some people, when it is necessary, so is it possible when it is necessary? If we go back in time to the 1930s or so, the incidence is actually going to be roughly the same, and the death rates are roughly the same as what they are now. But there's a very different detection rate back then, and people were dying at a younger age. But if you look back on the graphs, it looks like we're doing no better than we were in 1930s. There's been a big decline in prostate cancer death between 1990 and 2012, and then things have largely plateaued. A lot of that was because of the uptake in PSA testing, and so the early PSA testing has brought in a whole number of earlier tumours, and we've been able to get a diagnosis earlier and really alter the man's life expectancy as a consequence of that. But that only takes us so far. And we're really back to where we were as far as the death rates going back to 80 or so years. And that plateau that we're starting to see is really what we're needing to try and address. In order to get the death rate down, we really need to be shifting our goals and being a little bit more aggressive, but also smarter in what it is that we're doing. And now, really, this is a nice quote that they had that came out in the conference. People have been thinking, look, at the moment we're doing pretty well. We're catching these men at a relatively early age, and we're treating men with organ-confined prostate cancer or diagnosing organ-confined prostate cancer or putting them onto an active surveillance pathway. But then there's a lot of men as well with more advanced stage disease where some of the treatment options have been more limited, and or you've got men with advanced disease at diagnosis where it's previously been thought that there hasn't been a huge amount as far as curative intent treatment that can be offered for those individuals. The thought was that for people with nodal disease that this is going to become an impossible target for them. The thought really is that actually no, impossible's really just a word. It gives us a goal to work towards and gives us a challenge, and that really is what we should be looking at this particular point, really to try and get that death rate down. But how do we get that death rate down? It's not necessarily by doing more surgery, although that is going to be something that we need to do. And it's not going to be doing more radiotherapy, although again that's going to be something that we need to do. And it's not really just more drug therapy, but again there's going to be a role for that as well. It's really going to be about doing all of those things and all of them better and in the appropriate patients. But sometimes we actually need to be doing less surgery, because we want to be able to actually diagnose more men and have more men not afraid to actually get a diagnosis. There's a big stigma about having PSA testing. There's a lot of people who really would prefer not to have a diagnosis, and there's a definite shift amongst some GPs as well to try and avoid having a PSA test done with the thought that it'll open Pandora's box and people will just go down this pathway of radical prostatectomy by default, which really is not the case. Active surveillance is safe, which we'll have a talk about a bit later on. And so there is really going to be less surgery, but we still need to make that diagnosis. Radiotherapy has some morbidity attached to it, which a lot of people will be aware of. But radiotherapy, again, is becoming safer and safer and is becoming more targeted. And so we can better tailor the radiotherapy to the patient and also tailor the radiotherapy to different sites in the body, not just around the prostate, not just around the pelvic bed. Additionally, genomic testing is coming through, but at the moment, it's still relatively limited. The space on tailored drug therapy to an individual DNA profile, we're still probably 18 months to 2 years away before we'll be starting to have too much on that front. So we're not going to be talking about that tonight because it's still very much in its infancy. One of the really interesting things that came out from the talk was about biopsies, and actually we're really really at the cutting edge, if you will, about how biopsies are done in this country for the most part. In America, most biopsies are done transrectally still, as opposed to the transperineal approach. And we've very much shifted across to a transperineal approach for a multitude of factors here a number of years ago. Certainly at the SAN, where probably about 90% or 95% of our biopsies are done at the moment. In the US, the health model is different, the costing is different, and what's holding them back, this is a slide that they put up, is not really the training, because anyone can be trained. It's not really the cost of anaesthesia, because again, that's something that can be looked at. The model that they've got there is such that the office procedures, where they do their biopsies under local anaesthetic, they get rewarded more financially for than if they do them in an operating theatre. The health funds over there are essentially putting them into the office to be done because it's cheaper for the fund and better for the technician than if they're done in the hospital. So the whole system over there needs to shift to address the current paradigms that we've got. And they've tried to make their transrectal biopsies safe with rectal swabs and changing antibiotics and a whole lot of things, but they're really just denying the problem rather than fixing the system. So the US urologists have been doing things that we really aren't doing. And transperineal biopsy is the mainstay. I mean, you'll see who the author of this book actually was if you look. So transperineal biopsy is something that we've been doing for quite a while. I've written a textbook on it a number of years ago. And we're really leading the way as far as how transperineal biopsy goes around the world. There's a number of individuals here in Sydney and also in Melbourne as well who are really promoting the safety of it and the diagnostic accuracy of it. It interfaces really nicely with Fusion, both cognitive and MRI software assisted, and it really is allowing us to get a much safer biopsy and a more accurate biopsy. The United States will shift, it's just not there yet. For this slide, we've got an MRI of the prostate, and then we're doing a fusion biopsy of that. You can see how with software we can map the tumour within it and then get a very targeted and focal and safe biopsy. Unfortunately, America's just not there yet, which is interesting. Now, one of the other topics that we've been really pushing out at the conference is active surveillance and really trying to have a safe pathway for a number of individuals. The role of active surveillance is to try and minimise the population level harms of treatment, and it really needs to be used more. There's a fear of going on to active surveillance. There's a fear that cancers are going to continue to progress for men, and I've certainly seen it in my patients where the level of anxiety for some is just something they have difficulty dealing with, and people are scared to have a cancer diagnosis. I'm certainly aware of that. And they do have a cancer diagnosis, but it's a managed, planned treatment, and they need to view it as such. And we're very much trying to enforce the education, the trials that we've got, really the now longitudinal studies that we've got coming through, because active surveillance has been around for a while, are really showing that it is a durable management pathway for a whole number of individuals with very good long-term cancer control outcomes for the appropriate selected patient. Nevertheless, active surveillance shouldn't be viewed as not treatment or not giving any sort of treatment at all for those individuals. And it's going to, for some men, be about deciding when to treat. So they will have a diagnosis of low volume Gleason 7 disease, and if that man is young enough, you probably need to view that person as somebody who doesn't need to have no treatment ever, no active treatment ever, but they don't need active treatment now. And so for that individual, we can continue to monitor them very safely, actively, and then when a few paradigms shift, then we can go down the path of actually giving them some formal treatment. The things that have been shown to be beneficial for that are PSA density, which is the amount of PSA that the prostate is actually secreting relative to the volume of that prostate, and also multiparametric MRI scanning. Interestingly, I mean, Australia, again, is at the forefront of a lot of the diagnostic technology. We have ready access to MRI scanning at a relatively affordable cost. And fortunately, as of last year, the Medicare rebate has come in, which has made it relatively accessible to most individuals. In America, the cost for a scan is somewhere between $3,000 to $5,000 for a single scan. So at a individual level, it's expensive. At a population level, it really becomes untenable. So a lot of these individuals are not getting MRI scanning. So we're, again, active surveillance is something that we can do much better here, because we can do MRI scanning relatively readily here with a relatively good access and with minimal cost to the individual in the greater scheme of things. The goal of active surveillance is going to be to still leave a good chance of cure if things start to shift, and it really needs to be viewed as such. However, so it's not just deferred care, it's trying to leave all options on the table for that individual, but also spare any harms of treatment for those that actually don't need treatment. So I've had to borrow some slides, I'm sorry, as we start to move through, just because of the timing of only leaving the conference a couple of hours ago. Active surveillance, this is what's happening in the University of California, so San Francisco. So they're doing PSA testing at 3 to 6 monthly intervals for their men with active surveillance. And they're doing a repeat biopsy. The mean is around 15 months, somewhere between 12 to 24 months. And they were doing a rectal examination and a truss ultrasound, but not biopsy, at 6 to 12 months. So because they've got access issues to MRI scanning, they've got a dedicated ultrasonographer doing something that's really not shown to be all that beneficial over here. But they're looking for ultrasound changes, really subtle ultrasound changes. It's very operator dependent and doesn't really work, I think, outside of their centre. They've only really just brought in MRI scanning, and they're trying to fit that into their paradigms. Nevertheless, using their data, they've had follow-up to about 6.5 years, and they've found that on their men in active surveillance, they still get about a 98% overall survival, and a prostate cancer specific survival is 100% at 5 years. Men naturally might die of other causes over the time frame of their surveillance, which is to an extent what I as a urologist would like to see. I mean, I would like to avoid doing unnecessary treatment, active treatment for my patients if they don't need it. And if these people happen to pass away because nature takes its course from something else, well, that to an extent is going to be the best possible outcome for that individual, because we have spared them the harms of treatment that was ultimately going to be futile for them. Cancer-specific survival is great at 5 years. The concern that some men have is, okay, well, we're good for 5 years, but what happens if we don't, if I'm doing my radical prostatectomy later on? And what we've seen is actually that doesn't actually have too much bearing for them as far as bad oncological outcomes. Now, one of the things that they found was going to be useful, I should say, was about PSA density. We've sort of touched on that. So PSA density is a much better predictor for them rather than just overall PSA rise. There's a lot of noise to PSA around the place. But if they saw that the PSA density, so the amount of PSA per unit volume was starting to shift, then that really was a bit of a red flag for them. The other red flag that we've seen from some of the other published literature and also the talks over the weekend has been if they've got changes on MRI scanning. So really, if you've got a PIRADS 4 or PIRADS 5 abnormality on MRI, that's a red flag. Historically, at least when active surveillance was first brought in, it was limited to patients with Gleason 3 plus 3 equals 6 disease, really low risk disease. We're just starting to shift across in a bigger fashion to low volume 3 plus 4 equals 7 disease, so the ISIP2 prostate cancer. And we're seeing it safe. Additionally, one of the other populations that might be a bit concerned is going to be the younger patients. Younger patients, historically, we thought, okay, well, they're too young to put onto active surveillance, so we need to give them active treatment now because that gentleman's only in their 50s. Active surveillance is going to be something that's going to be better for the person in their 70s. Actually, for these men that if they did proceed to radical prostatectomy, they're no more likely to harbour aggressive or adverse pathology whether they had their operation done and they're in their 50s or their 70s. Essentially, their cancer outcomes are the same whether they are done irrespective of age. So it is safe for a younger individual. Their tumours, once they have a tumour, really operate along similar sort of biological grounds. Additionally, low volume 3+4 patients are safe, provided they are appropriately selected. Here we are looking at the follow-up curves, and there is a little bit of upgrade that happens. And it is important to note that for patients who are on active surveillance, that some men do come off. And so what we're seeing here is that for people who are less than 60, they do come off active surveillance at a slightly higher rate than men who are over 60. And so if you're looking at 5 years, about 40% of those men less than 60 have come off active surveillance, as opposed to patients who are over 60 at time of going onto the protocol, where at 5 years about 50% are. A lot of that is going to be because then once they start to develop a clinically significant prostate cancer on repeat biopsy, that patient is now old enough that the likelihood of that disease killing that man in their lifetime on sort of an actuarial level is going to be relatively low. And as a consequence, you've been able again to safely spare that individual the need to shift from active surveillance to active treatment. Whereas if a man goes on to active surveillance at the age of 50, he's still at 50 got another 35 years ahead of him, say. And so at 55, 5 years after diagnosis, he's still got another 30 to 35 years ahead of him. And so if his tumour biology is starting to shift, it's not going to be safe to leave him untreated for 30 to 35 years. But his pathology, when you actually go taking his cancer out, is going to be no worse than if you did it earlier. So it's a safe treatment. As I said, the things that are going to be predictors to come off of it, climbing PSA density and or high-risk MRI features. There are things that were, should say, the preoperative predictors of pathology being adverse at time of radical prostatectomy. So on this slide, what we've got here is there is no statistical difference between the Gleason 3+4 and 3+3 as opposed to the one below. Essentially what we're seeing here is the 3+4 and 3+3 are going to be the same compared to the 3+4 with multiple cores. So you can treat single core Gleason 7 the same as you can do Gleason 6 if they're going on to active surveillance. Whereas if they are becoming multifocal, high volume Gleason 7, you've selected the wrong patient for active surveillance. So there's a difference in the hazard ratio, and the p-values are quite different depending upon whether you're one core or whether you're two cores positive or two zones positive for Gleason 7. So low volume 7 we can surveil, and we've got now data to support long-term surveillance for low volume 7 disease, which is actually what a lot of our men at diagnosis will have. And again, there's going to be more evidence to try and support the rationale behind actually not being overly fearful of getting a diagnosis and really not avoiding the PSA test, which some people are trying to do because they're scared that they'll have a diagnosis made that will lead them where they don't want to go. If we come across and we have a look at the old risk profiling, additionally, or previously it was going to be basically the Gleason score and the volume of tumour. Now with new modalities coming through, we have better MRI scanning. We've got the multivariate risk models that can really bring all of the PSA density, the volume of tumour, what the fused biopsy is, where we can do additional samples. And potentially we'll get some genomic sampling coming in as well. There's Oncotype DX, which is available in the United States. We're looking for changes in the tissue around where the biopsies are done. It's never really caught on over here, and with PSMA PET scanning coming through, it probably never will do. But essentially when active surveillance was first brought in, very much limited just to that when they were writing the protocols. We've now got a lot of additional information to come through so we can further refine the selection of patients that will go on to active surveillance. What that will hopefully mean then is that we can additionally target those people that need to be treated and not treat those patients that don't need to be treated. The overall survival is between the 3+3 and the 3+4 is good. If you break it down to the single core or the multiple cores of 7, this is really the crux of it. If you're looking at the PSA-free recurrence after they've had their treatment, so if you delay their surgery because they've been on a surveillance protocol, something has shifted, they now need to have treatment. There is no difference between those patients who end up with multifocal 6 and low volume 7, essentially by the time you get out to 3 years from treatment. Whereas there's quite a big jump between there and there if they start to have high volume 7 disease. And that will, as we move forward, start to play out. Regardless, their survival is good. So their prostate cancer survival is 100% through the 3 years. And the metastasis-free survival is again going to be very good for a lot of these individuals. So thus, it's safe in low volume disease. We're really starting to see that. And multifocal 7, however, puts the patient at risk of recurrence later on and at risk of potentially having some early metastasis later on. And so that's not going to be the patient for us to really actively think about putting onto an active surveillance protocol unless the patient is suitably educated and that's what they want to do. The only difference is if we start to bring in PSMA PET scanning, and we're very happy that we can monitor them in a different way just to the standard protocols. That will be a work in progress. So if you look at our candidates for active surveillance, this will probably be how we're starting to look at patients. And so those that will really have a diagnosis made, if they've got high volume disease, if they've got an MRI scan that is really concerning, if they've got aggressive architecture, the cribriform architecture or intraductal components, these people need to have treatment. Be it surgery or radiotherapy, they need to have treatment. They're those that have really poor health, they've got other comorbidities, they've got advancing age, then watchful waiting is still going to be a very appropriate path of management for those individuals. And for those that have a low PSA density, if their repeat biopsies are negative or we can't find any cancer at all on them, if their MRI scans remain favourable, and eventually if their genomic testing is favourable as well, then we could go down a less intensive pathway of surveillance for them. So we really will be able to tailor the surveillance protocol to the individual. And these are sort of the cautions, if you will, do. So obviously we mentioned high PSA density. The other thing we should note, lastly, is BRCA. So BRCA, which is the BRCA gene, is the one that's associated with breast cancer, but also early and aggressive male prostate cancer, as well as ovarian cancer. Men with BRCA, or men really who tell you they've got a strong family history of prostate cancer, are not going to be great candidates for active surveillance pathways, because you're very likely going to have them be an escape and early, if you've got a diagnosis of prostate cancer now, that individual, whilst they're on surveillance, if you will do, and you're not doing anything actively for them as far as curative intent treatment, they're likely to develop metastasis. So you really should take your window of opportunity for them, or at least actively monitor them very closely. But they're relatively rare. So this is really their synopsis from the University of California, is that active surveillance is really about timing of treatment for some individuals, and selecting the appropriate patient for treatment as well, or avoiding treatment altogether if you've got a low risk individual and the repeat biopsies are low. And active surveillance is going to become safer and more acceptable for people in the community, especially as we're shifting, or in America they're shifting away from transrectal to transperineal ultrasound. Any questions on active surveillance?
How many, James, out of the, I don't know how many people get diagnosed each year with cancer, prostate cancer, how many are liable to be beneficiaries of this?
Oh, look, I would say in my practice we'll be looking at about a third, or maybe 40% probably will go into an active surveillance pathway.
And it's only for about, based on that graph, it's only about a year and a half or 2 years you seem to be able to defer that treatment?
No, very much not. So you'll have patients that'll be on surveillance for years. So on that graph before, you had, depending upon the age of diagnosis for that individual, people are falling off. But if you get out to about 5 years from commencement of a surveillance pathway, If that man is young, then about 50% will have come off surveillance. If that man is an older man at time of initiation of surveillance, then 60% of them will still be on a surveillance pathway at 5 years. So it's not just keeping them on it for a couple of years. No, these people are going to be on it for hopefully for a more prolonged period of time. What we don't yet have is great guidelines for what to do after 5 years. So the Prius protocols that were written a while ago and a few of the other sort of Klotz's data, they were following up for a set period of time and then follow them up in a sort of ad hoc manner after 5 or 6 years. You really start to get an understanding upon how stable that individual's prostate cancer is going to be after about 4 or 5 years. And most of the people will declare their hand earlier in the piece rather than later.
And the two-thirds of your patients, and presumably the rest of the population, that are not are 8, 9, 10 Gleasons? Is that what?
No, look, I'd say most of my patients are going to be multifocal 7, because that's just what most people are. They're going to be large volume 7 disease, and or smaller volume pattern 8. So 4 plus 4 equals 8 is going to be a larger volume of those people that will be getting active treatment. And then you get a few of the people that are going to be Gleason, 5 plus 4 or 4 plus 5 equals 9 at diagnosis, who, no question, will need to have treatment done and promptly. The conundrum is going to be the multifocal 7s who are concerned about preservation of function, but long-term need to have treatment done earlier rather than later. The conundrum's not so much for me, the conundrum is for the individual who has options in front of them and doesn't know how to choose. There's information available, and then it clouds judgment for them. But reality is they don't need to make a judgment decision today. It's all relatively slow progressing, and the aim for treatment for these individuals is to not normally save their life today, tomorrow, next week, next month, next year. It's to alter things 10 to 15 years out from now, because it is a relatively slow-growing disease process.
And so are those third that are potentially for active surveillance. Are all of them accepting that, or are they, because there's cancer in my system, wanting to get an operation and get it out?
I've only had, in my practice, I can only recall one individual who didn't like ended up seeing somebody else who told him again, no, you need to continue with surveillance, because the other urologist that he saw again was not keen to go doing a nominally futile procedure on him. Some people just have high degrees of anxiety. People in their population have anxiety for all sorts of issues. I view it personally as my role to see the person and continue to reassure them. They just need more time. They need more education. They need longer consultations, more material provided for them, and appropriate information from the literature provided to show that what they've got is safe and it's in their best interest to continue to monitor them. With increasing scanning available, we can go doing PET scanning on them to show that what they've got is going to be a relatively biologically inert tumour. So if they've got a PSMA PET scan that shows that their really trivial Gleason 7 disease is going to be more of an incidental finding rather than something that needs to have treatment, they should take that as a point of reassurance. If there's a discord on that individual, or really any individual, if there's a discord between their biopsy results and their MRI, or their biopsy results and their PSMA PET scan, well, we really need to be going and thinking, why is that the case, and doing repeat biopsies earlier rather than later to look for a more aggressive malignancy. But for most of these individuals, they've got so most of the patients on surveillance, they've got a relatively indolent tumour, and it's a matter of keeping them well whilst they've got an indolent tumour, not giving them treatment-related harm, and picking them up early while you've still got all the options on the table to offer them curative intent treatment.
Thank you.
Okay, so molecular targeted imaging is another thing that we're talking about. So what we're looking at often is going to be the use of PSMA as a way to try and have a look at who needs to have treatment. What we really want to try and do is stratify the patients who might need to have treatment. as we've sort of said, there's the low-risk individuals who will go on, ideally, onto an active surveillance protocol, because the likelihood of them having any sort of cancer-related harm is going to be relatively low over time. You've got the intermediate risk individuals who would need to have curative intent treatment with one treatment or another, so surgery or radiotherapy, and they've been done in different forms depending upon patient's preference. Then you've got the high-risk individuals who really need to have the kitchen sink thrown at them. So they're going to be needing radiotherapy plus potentially surgery, or surgery plus radiotherapy plus adjuvant treatment. They might need to have neoadjuvant chemotherapy. I mean, there's a whole host of things. And this is, I think, really the high risk, which we'll be talking about shortly, is really where a lot of the focus is going on to at the moment, because these are the men that die of prostate cancer, and they die quickly. And they really need to have aggressive treatment done early in the piece in order to get the best volume of cancer cell killing going on while still treating that individual whilst they're a relatively young, healthy and robust individual. There are some reasons, however, why prostate cancers kill. So there are 7 reasons, I should say, why prostate cancers kill, while some others don't. I mean, there's a lot of variability between the prostate cancers. One is that there's going to be some difference between the actual prostate cancer cells themselves. There's going to be some differences within the genome of them, so not every tumour is going to be the same. There's going to be difference within the microenvironment within where the prostate cancer is actually sitting that makes one cell want to jump ship and metastasise and one not. The tumours themselves are to an extent polyclonal, meaning that they're a clone of an individual sort of cell that went bad, but there's lots of clones. They're not all the same cell. There's a lot of variability between the individual and within the tumours themselves. So one prostate cancer is not the same in different sites within the body. And that's why if you treat them with chemotherapy or androgen deprivation therapy, you will remove some of the cells that are sitting there, but you won't remove all of them, because they will have an inherent resistance because of mutation that is developed within them. There's also going to be some individuals who have particularly bad variants, the intraductal cancers. You'll have some patients who you're going to miss their tumour early on because they've been invisible to MRI scanning. So some of the more central prostate cancers, unfortunately, are relatively MRI occult. And those cancers can present later in the disease process, unfortunately. It's just a limitation of the current technology that we've got. And some people will have a predisposition to cancer at the germline. They'll have a BRCA mutation. There's going to be other reasons as well. If we're looking at prostate cancers, I don't begin to pretend to understand these, but there's a map of their genome. There's a lot of variation between the prostate cancer and the various mutations that exist within it. There's this concept of nimbosis, which was discussed, which is about a co-occurring aggressive features that come about in order to bring about a metastatic cascade going on, and also really to make these cancer cells try and leave where they are within the prostate and start to spread. It's normal for a lot of individuals to start to develop little tumours around the place, but it's not normal for those individual tumours to start to leave. And this happens for everywhere in the body. The body's immune system normally is coming in and replacing them. They will normally be turned into an off state and not allowed to reproduce. Something is happening that is allowing these cells to start to break ship. Surgery is one of the big things that we've been talking about. So and the real concept that we're trying to was being promoted was about the total eradication of disease. The high-risk individuals, those people in the bottom of that curve before, are those individuals who really we need to go throwing the kitchen sink from a cloud at them. Low-volume metastatic disease can potentially still be viewed as something that can be cured. So patients who have low-volume lymph node metastasis at time of diagnosis shouldn't necessarily be written off as people who we are not able to treat, who aren't going to be suitable surgical candidates, or for whom radiotherapy is going to give control but not necessarily a cure. But it's often going to be requiring a combination of treatment of both systemic and local treatment in order to give a long and durable control and or cure to those individuals. Now, we can't promise to offer this for everybody, but certainly if we don't if we don't look to try and do the impossible, we never will. There's a quote I like from Wayne Gretzky. I don't know if you know who Wayne Gretzky is. So I mean, he's got two. Pardon?
Baseball.
Hockey player. So yeah, the greatest hockey player there was. So when he had two things about how's he so good, it's not because he skates to where the puck is, he skates to where the puck is going. The other thing was about how do you get so many goals? And it's the reason he gets so many goals is because he tries. Because if you don't swing at the goal, you'll never get it. So the only way to get a goal is to have a swing. And for some individuals, unfortunately, we do need to have a swing. Individuals as well often like to have a swing. They much prefer to have something done for them rather than to not, for the appropriate individual. One of the reasons why we want to be aggressive for some of these individuals is because the spread that is happening is not just from the primary malignancy to the metastasis, but also from the metastasis to another metastasis. There is signaling happening throughout the entire body. So you have a met to met spread, and it's actually far more common now, which has been shown, than just primary to metastasis. So we need to treat potentially the primary, as well as potentially treating and removing the metastasis as well. So a more aggressive treatment early on is going to do that person favour. They'll pay dividends later on in the piece. Androgen deprivation therapy alone does not prevent disease progression. It holds things at bay, but it is not going to be viewed as curative. It's going to be a palliative treatment. Good palliative treatment, it has side effects attached to it, but it's not going to prevent later palliative therapies from potentially being needed for some individuals. So we need to think, how can we get better local control, and how can we remove a persistent source of these metastases spreading throughout the body? And we'll also potentially offer an improved response to systemic treatment if we can go downsizing the volume of tumour that is sitting there. So one of the goals that we should then have is to try and shift the natural history of the disease. So rather than just have a diagnosis, so a diagnosis here, and then eventually patients get their symptoms from metastasis and then they die, we'll have the diagnosis made. Potentially they might have oligometastasis at time of presentation, but we can identify them and treat them. So we're going to give early and targeted treatment to those individuals, be it surgery or radiotherapy, and or combination thereof. And then we can go on giving additional targeted treatment to them, and additional chemotherapy and androgen deprivation therapy and modifications of androgen deprivation therapy, potentially some immunotherapy as well, or PARP inhibitors. And then we're going to shift things to later on in life to a point where to an extent it becomes immaterial whether that person is going to pass away from prostate cancer or pass away from something else. For a lot of people, if you can shift the goalposts that far into the future, good number of years, then the death from prostate cancer becomes a death from something else for that person. And so we really need to view, for a lot of people, especially younger people, that giving targeted treatment and aggressive targeted treatment early on is really going to pay dividends to them later on in life. You might be able to stop a person with diagnosis of oligometastatic disease at 50 from dying at 65 and allow them to pass away at a more reasonable 75, which for that 55-year-old man is going to have a big difference in that person's quality of life. It's a difference of seeing what happens with their kids and a few other things. So it really will have a big change to these individuals' lives. The surgery for these oligometastatic patients, the treatment might result in a decreased tumour burden, should hopefully decrease their morbidity and increase their survival. But we can't offer that for everybody, so we need to be viewed as such. Some of the trials that have been bringing in, and there's a nice trial that's going through the States at the moment, is looking to see what the maximum therapy is that can be given safely. And the early indications are that it's going to be potentially something that's going to be useful.
Generally failing over time. But it also gives us something to shoot at to say, things men with metastatic disease do live quite a while. They are living longer with our multiple therapies, but we're not curing them. The idea that we should treat the primary is another major discussion point of this meeting. And of course, we saw from Dr. Ost earlier today, this radiotherapy to treat the primary tumor in the Stampede trial. A lot of controversy about whether this should be a new standard of care or not, but it does demonstrate that, again, patients with a low metastatic burden seem to benefit from treatment to the primary. But the issue is there a difference between these two patients?
Essentially, metastatic cancer is metastatic cancer. And we need to view metastatic cancer as metastatic cancer. We don't yet know how far we can push the treatment of metastatic cancer as far as treating the primary as well, whether there is going to be a huge difference between these two individuals. This individual, obviously, this is a nuclear medicine scan with multiple lymph node metastasis around the place, as compared to this individual who's got more limited spread around the place. We don't yet know if there's going to be a huge difference in treating the primary between these two individuals. One would have to suspect that that individual is going to do better than that individual, but how much better we actually don't yet know. Historically, this individual would have been deemed to have systemic disease. The horse had already bolted, and treating the primary wasn't going to be a beneficial thing for them. They're really trying to shift to start avoiding getting to these individuals and starting to treat them when they are closer to here, rather than allowing them to continue to progress to there. The reason for that, I like the quote that he gave, essentially is once you've got 1 billion cells around the place, tumour heterogeneity starts to defeat you. So the variation between the cells means there's going to be enough mutations between them that no matter what sort of chemotherapy it is that you're giving them, there will be a resistant clone somewhere that will start to defeat you, because there's going to be 1 billion different potential mutations around the place. 1 billion cells is going to be a tumour of around 1 centimetre in size. So if you've got a lymph node metastasis that's around 1 centimetre, you're looking at 1 billion cells roughly. You start to have multiple centimetre sized lymph node metastasis, you're looking at multiple billion cells around the place. So you have multiple potential variations or combinations to give resistance around the place. So we're really needing to ideally think about doing treatment earlier on in the piece of the oligometastatic rather than later on in the piece. It is nevertheless a slippery slope. We don't know where on that slope is going to be the ideal spot. There is definitely the concept, I'm not sure if you've heard of oligometastatic, which is going to be a more limited number of metastases, hopefully a more treatable level of metastasis. For an arbitrary reason, 5 was deemed to be the number that oligometastasis could be, but it is really arbitrary. Whether it's 4 or 6 really probably doesn't change much on a biological level. So we don't know whether the treatment of the newly diagnosed oligometastatic person is going to be possible as far as giving them good level of durable treatment. We just don't know, it's too soon. We do know that chemohormonal therapy alone is not going to be curative, and we do know that surgery alone is not going to be curative, and androgen deprivation therapy is going to be palliative. But if we can give all of it together, then anecdotal evidence would suggest that the consolidation of the disease treatment is going to improve disease-specific survival. It's technically achievable. Surgery is safe for these individuals. It's not that much more complex than doing it for patients that have more organ-confined disease. And for the all-in patient, going to war is probably the way to go. If that patient is suitably counselled, and that's what they're wanting to do. But certainly doesn't suit everybody. And we don't know what their long-term outcome is going to be. But there's definitely a trend towards trying to tackle these previously considered incurable patients. And that hopefully is how we can start to bring down the survival curves, which are starting to plateau, by having these high-risk individuals who previously were deemed to be incurable and think, actually, maybe this impossible disease is something that we can start to cure. The patients themselves who go through this, and I've had a couple individuals, their quality of life is very good. They go from having a defeatist view of things to a very positive view of the life ahead of them to expend. Obviously they would prefer not to have prostate cancer for understandable reasons, but you've given them a fighting chance. Rather than saying that there's nothing that can be done for you, you've really, for this young 50-something-year-old individual, given them the best possible chance for cure that can be done. In addition to that, you've spared them a lot of the potential morbidity of late-stage prostate cancer, the frozen pelvises and others, the ureteric obstruction, the other sorts of things that people would prefer to avoid. That could happen for these people with really advanced disease later on. One of the interesting things that I did general surgery before urology, and I did plastics before that, is that for the patients that had really traumatic limb injuries, they often didn't get immediate amputation, I noticed, in the trauma units. They would potentially go through futile surgery early on in the piece, and then they could have their amputation. And they might be in hospital for about a week or so. You have a couple, not sham procedures, but procedures where you knew the likelihood of saving that limb was going to be relatively low before they had the amputation. The reason for going through that was because had been shown previously that those individuals who had woken from their horrible trauma to find that their limbs were amputated had a much higher rate of PTSD than those individuals who woke up from their horrible trauma with limbs intact, had gone through salvage surgery that was unsuccessful, and then had consented to having had a limb amputation, rather than having things taken away from them. And I would view the treatment of these high-risk younger prostate cancer patients to be similar to that, in that they have been given an opportunity to have a say in what it is that they want to do. You've not taken options away from them. At least that's my personal take on it. Can't find any literature to support it. That's the analogy that I can see. Now, we know that the control of the primary tumour is linked to longer survival in men with metastatic prostate cancer. This is sort of one of the arguments that's going behind it. So there's a couple papers that are supporting that. And it's been around for a little while. Some paper from 2014 again from 2016. So the Hopkins trials that they're looking at, so there's the TED1 and the TED2, which is the total elimination disease, looking at the neoadjuvant patients, so prior to prostatectomy they might get some chemotherapy, and adjuvant patients who are getting some early chemotherapy afterwards. The reason why they can do it is because we don't yet know exactly how this is going to happen. We don't yet know really what's going to happen if we didn't do that. So we do have some degree of equipoise, but it's hard to randomise it. So we can't, in good faith, offer to randomise patients if we think we might not be giving them some of the local therapy that would be advantageous to them. This is one of the trials, you hopefully get the slides. So this is the protocol that they've got where they're getting neoadjuvant treatment. This is the TED1. They're getting consolidation with prostatectomy and or radiotherapy. And then they're getting some systemic consolidation afterwards with some more radiotherapy. So the neoadjuvant treatment that they're getting is chemotherapy with docetaxel, plus they'll have some androgen deprivation therapy, plus they're having abiraterone. You'll downsize these tumours. You'll see that there's going to be a treatment response on your scanning. Then you can get local control. Local control meaning removing the primary prostate cancer, surgery or radiotherapy depending upon patient preference and a few tumour characteristics and what their functional status is like. They've got disease outside the pelvis, so they're going to have metastasis in bone and or lymph nodes around the place, axilla, and that's where you can go doing your focal radiotherapy to those with SBRT or SABR, and really try and sterilise those extrapelvic oligometastasis. And then they're getting follow-up treatment afterwards. And the results are actually not bad. And so for these really high-risk patients, they've had 40 patients, 15 were pre-abiraterone and 25 were after abiraterone. Average age 43 to 75, so 43 obviously a young age for that individual. Average is 59, still it's a young average age for these people. PSA 1.6 to 184 at time of diagnosis. The individual I can remember was 100 at time of diagnosis when I met him. PSA of 1.6, that'll be an awful tumour. So although the PSA is low, that's going to be a non-PSA secreting tumour. It's going to be so far mutated that it stopped producing PSA. So it's not going to be your standard prostate cell. So don't view the PSA as being the metric for him, for that man. Of those patients, 38 patients had a radical prostatectomy, 1 deferred out of treatment, and 1 patient had radiotherapy. And then if you're looking at those individuals, the patients did well. So 36 patients had a PSA less than 0.1, one patient 0.7, one patient 0.1, and at 1 year, really, all patients continued to have a PSA less than 0.1. Now, we don't have long-term data, this is short-term data, but these patients have had their pelvis cleared, you prevented the long-term sequelae of it, and they've got a durable, to an extent, degree of PSA control. When you consider that historically for patients with metastatic disease, the median survival would have been closer to about 3 years. And so these patients have really shifted a long time already from those two different curves where we've altered the natural history for these individuals.
So James, could you just repeat what they had done? They had the primary taken out.
So they've had neoadjuvant, so on the TED1 trial, they've had neoadjuvant treatment with docetaxel or taxotere, so chemotherapy. Ideally, you get 6 cycles of it. And then they've had abiraterone or Zytiga, which is one of the CYP17 inhibitors to drop down the intracellular testosterone within the prostate cancer cells. They will have had an LHRH agonist, it says at the bottom as well. So they've had their standard androgen deprivation therapy, pick your brand, but they all have had androgen deprivation therapy. What they had in the United States for this protocol, I'm not sure. They will probably have whatever the standard of care was at the Hopkins Institution. Then they've had consolidation, so they've had systemic treatment with chemotherapy, abiraterone, and androgen deprivation therapy. Repeat scans, and then they've had surgery and all radiotherapy to treat the primary. And you'll have had a lymph node dissection done to clear the pelvic lymph nodes, or radiotherapy to the prostate and the pelvic lymph nodes. Then they've got disease, because if you go back to that map before, it stopped working. So you've had treatment systemically through the whole body, so the whole body is getting treated with the systemic treatment. You've then treated the prostate surgically or radiotherapy. You've removed those lymph nodes surgically or with radiotherapy to sterilize them. Now, they're not going to had focused radiotherapy to all of those spots because that's too much to go doing. But if they've had isolated skeletal metastasis and or say L5, L2 vertebral metastasis or a single axillary metastasis, you can give focal radiotherapy to those sites because the crossover in the radiotherapy fields is not going to be there. So it is going to be safe to give targeted spot welding essentially with the radiotherapy to those multiple sites. Now, you're not necessarily going to be able to come back and give radiotherapy to that site again in the future, but you will have been able to treat it at this point in time. And so you've cleared multiple sites all at once, and they'll continue on with the LHRH agonist afterwards. Oops.
And how long would that have taken, James? I mean, you know, there's a lot going on there.
Probably 18 months all up.
And then it's still ongoing.
Well, they will
cured.
Well, that we don't know. I mean, that's the thing. For these individuals, we don't know. Talking with some of my colleagues at Vinnie's who've had more, longer years with that, about 25% of men, anecdotally, have been able to have durable, multi-year prognosis from this. Not everybody does, but certainly some individuals can do, which is better than none. 25% is better than none. And so, really, what we've gone there. So, the TED2, sorry, just to move through. So this is what we're looking at there. So this is their registry data. This is their 2-year data. So of those patients, because you've hopefully stopped some of their androgen deprivation therapy, they've had a testosterone recovery. So of the patients who had testosterone recovery, half of those have had a biochemical recurrence, meaning their PSA started to rise. That's okay. 45% have remained in remission. So the testosterone is back up, but you still can't find any PSA recurrence, which is great. And there's no relationship to a stage or site of metastasis for those individuals on that trial. And for those patients who did not have any testosterone recovery, because not all men get full testosterone recovery after androgen deprivation therapy, for those individuals who remain castrate, then none of them have had PSA recovery either. So it's for these individuals here, they're actually getting relatively durable control. Relatively, 2 years. But 2 years for these individuals is going to be better than no years. And you can keep on adding extra on to this. This is the start. So this is the start of treating these men. I wouldn't view this as the end of what we can offer them. And so what we're potentially going to be able to offer is going to be alteration in their overall survival, alteration in disease-specific survival, and altering the time to progression. What the patients notice as well is going to be that you're avoiding some of the needs for salvage for them, because otherwise these individuals might get obstructive lower urinary symptoms requiring a TURP. They might start to get bladder invasion with the tumour fungating up and into the bladder, which can cause bleeding. They can get urethral obstruction needing stents or nephrostomy tubes. And if you're delaying treatment for them, you might still end up needing to do some sort of surgery or radiotherapy for them, but you will have missed the treatment opportunity, the more curative intent for them. And for some individuals, they get pelvic exenteration because they've got tumour invading into the rectum, which is a really, for these T4 pelvic floor invasions, a really morbid operation to go putting those patients through if they've really got limited pelvic disease without true spread outside of it. So the rationale behind it, I mean, it's largely retrospective for some of this data, other than these TED Talks, is that you get an improvement in overall survival and you can help stop some of the symptomatic progression. And potentially there's going to be removal of the lethal prostate cancer in the primary tumour before systemic therapies. So removing them in the prostate, you're going to limit some of these really highly aggressive cells from jumping ship that might be resistant to systemic treatment later on in the piece. And so we know that the systemic treatment that's given for prostate cancer, if you go and re-biopsy the prostate, you will still find some active prostate cancer in the primary organ. And so if you can remove the primary, you can hopefully stop some of these aggressive tumours from being around. What we don't have is a great randomised controlled trial for this, but it is feasible and it should be done. And hopefully that's which we're going to be in. So rather than just in small subset data or registry stuff, we should have a randomised control for it to truly show that this is a good option for patients. So it's all very well for centres like Hopkins to be offering it, or a few ad hoc patients here to be doing it, but we really need to be doing it in a proper trial setting. And so that's really what we're hoping to get. And so it's a great trial concept. They're accruing patients, it's continuing to accrue patients, but we don't know what else is lurking under there. And so the problem is that maybe we're going to make these people look good, their scans are going to look good, tumours normally will melt away, but we don't know what's going to be there 2, 3 or 4 years down the future, how these things will come back. We just don't know. So how can we enhance the surgery for early disease? Now, so this is another interesting thing. So this is a very limited trial as well, which is using a white light, so really what we're looking at, and also near immunofluorescence. And so the hope, and you'll see a little video in a second, is that we can target tumours better at time of surgery. We can improve the accuracy of surgery, we can decrease the positive margin rate, and we can increase the detection of missed nodes. Potentially we can also use it in PSA recurrent disease. So the trial that's been done is called the PROMOTE study for the prostate cancer molecular targeted enhanced surgery. You suspect they've chosen the name to fit.
Here, which shows no fluorescence whatsoever, and this was confirmed histologically. And this final one, please. And this one shows again the prostate pushed to the side, neurovascular bundle, and here an area of fluorescence which we biopsied, and it showed that this was cancer. So we are getting to a stage where we think this has promise and will work.
So they need, the way the system is at the moment, it's done with a robotic scope, but also a different camera. They need to flip from one lens to another. It will eventually, you can see already that this is going to be where we're heading, is that you can have an immunofluorescent tracer in there. You flip from your white light that we all see across to an immunofluorescent, and basically your tumour will light up. And you can say that we need to be here rather than there, or there's still lymph nodes there that we otherwise will have missed. Because at the moment, we really know that the long-term cancer-specific outcomes between surgery and radiotherapy are largely going to be the same. And that's despite surgery having, unfortunately, some patients who will have a positive margin on, or some patients who there might be nodes that are left untreated. We think we've got the lymph nodes, but then you go on afterwards and there's going to be another lymph node that pops up. If you can improve your lymph node yield by actually getting the positive lymph nodes, and if you can decrease your margin rates, then surgery you can think will shift ahead as far as cancer control goes and long-term durability compared to radiotherapy for primary treatment. Sorry, it's done twice. So that's something that's on the horizon. It's still on a very limited trial in the UK, but we should start to see it shortly once it's commercially available. So it's really gone through a very small number, but it's really quite exciting to start to see it. There's been a lot of talk at the conference about pathology and about really why is it that some cancer cells metastasize. So the earlier slides were meant to be about this as well. And why are some tumour cells resistant to chemotherapy or androgen deprivation therapy? Well, there was this nice concept about the cancer swamp, and you really need to sort of drain the cancer swamp, if you will do. But you've got this collection of immigrant cells that will try and jump out. And one of the reasons for it is because the environment in there is going to be relatively inhospitable for them, and they want to leave. A happy cell doesn't leave. And the really nice analogy of the difference between grasshoppers and locusts, which is really nothing, except what turns a grasshopper into a locust in the next generation is a lack of food. And so if you have a hungry grasshopper, the offsprings of those grasshoppers become really aggressive locusts. If you have a happy cell sitting in the prostate, it might not want to leave. But if something changes, the stress in that prostate starts to change, that prostate cell, which is resistant to programmed cell death, can jump ship and start to look for a host elsewhere, which is going to be better for it. And so the thought is that there's this diaspora that might try and push these immigrant cells out. These cells that move have distinct morphology and movement characteristics. The really scary thing, and there's a video here which goes for about 5 minutes, is about these polyclonal giant cells. And that's the polyclonal giant cells which we've got in here. This is groundbreaking. This is true. I've never seen it before the week. This is truly groundbreaking. These cells were thought to be rubbish. A lot of the analyzers that are used to look at cells are actually just basically computer algorithms which look at breast cancer cells or look at prostate cancer cells and say these cells are that, these cells are this. And these were thought to be just basically lumps of crud and were programmed to be ignored. But actually they're active polyclonal cells. They are lots of clones all merging together, and they become resistant. They downregulate their cell surface markers so that they avoid the body's immune system, and they're basically just a big clump of cancer that hides and can live dormant. And there's a nice video, but a very scary video, of these polyclonal cells repopulating.
Sorry, I'm doing multiple, I gotta show you the movie. There it is. So what you see now is you're gonna see this chemotherapy wipe out the cells. And you see it gets black. But then as you see time progress, you see these big cells invade into 10 nanomolar docetaxel. And they're walking around and they're really busy and they're hypermotile and they're really huge. And then towards the end, all of a sudden you see this bloom of little cancer cells that represent that resistant bloom you saw earlier. Here they come. So now I have the question, what are those large cells and what are those small cells? And how does that relate to the birth of resistance and lethality in all of our patients? Well, to make a long story short, I'm going to give you the summary in case we run out of time. What happens is cells fuse, they form large polyploid giant cells, and those survive, and then when the stresses, they punch out these little cells by meiosis that are resistant amplifying stem cells to repopulate a tumor. So what you're seeing is that not tumor cell heterogeneity necessarily that mediates resistance, it's these polyploid giant cells. It turns out that these have been known about for the last 50 years in the literature, and they've been associated with chemotherapy, radiation, low oxygen, low nutrients, but because everybody had a static picture like you would see it on a tissue slide, it was always assumed that they were giant cells that were going to die, that they were going to die through mitotic catastrophe, or that they were senescent. And it's only because we have a movie that we now know that these are actually functionally extremely important cells that have changed the way I think about why people die of cancer. So the next thing we did was that, well, are these present everywhere? Well, it turns out that if you look in a tissue culture flask, any tissue culture flask around the world, these actually exist as anywhere from 1% to 5% of the population. We said, oh, we did this because we used a mitotic inhibitor, docetaxel. Not true. We can induce these through treatment of any kind, including hormones and radiation. And then we can do it in a dose-dependent manner. And because we don't look through microscopes anymore, it turns out that there they are in tissue culture, but there they are after 3 days of treatment with chemotherapy. They're all that's left in a tissue culture flask. So you can say to me, well, Ken, that's really cool, but it has nothing to do with real life. So, wrong. What we did was we said, well, do we see these in patients? And the idea was, well, pathologists would say, well, maybe, but you can't tell two nuclei together whether they're one cell or 3 cells. Well, so Angelo DiMarzo, my good friend and our pathologist at Hopkins, stained prostate cancer mets with EpCAM, which does the cell periphery, and sure enough, hiding in the tumors are these polyploid giant cells. And the more you treat, the more you get. The more aggressive disease, the more you have. And then we said, well, if they're so motile, we should see these in the circulation moving to different spots. So I asked Peter Kuhn, my friend at USC, who's looked at 10,000 patients with circulating tumor cells with his EPIC platform. And he said to me, Ken, I never see them. And the very next day, his student sent me this picture of one of my patients. And I called him back and said, Peter, what is that? And he goes, oh, my computer algorithms are trained not to recognize those cells because we thought they were schmutz. That's a technical term. So they're there, and now he's redone all his algorithms, and now he finds them all the time, and he can tell the difference between clusters and single giant cells, and he can tell whether they're Bymen positive or negative, CK positive or negative. And so this has changed his way of actually looking for circulating tumor cells and which ones are potentially important. How are they formed? I can tell you they're formed by either doubling their DNA and their nuclei and then not being able to separate. That's called aborted cytokinesis. They're also formed by cell fusion. And this is work we've published, but just for fun, I'm going to show you one more movie. So these are PC3 cells that have been exposed to chemotherapy. They are histone labeled, and so they're stressed. And for the first time, you're going to watch 2 cancer cells fuse. And let me tell you, folks, if you're not terrified, you should be, because that's why people are dying. So how do these cells survive and beat therapies? Well, it turns out they have a stress sensor. And so we labeled the cells with the Fuji label, which tells you where they are, where a cell is in the cell cycle. And it turns out that these buggers, when they sense stress, they go right into G0. They exit the cell cycle and they protect their DNA. Because the way chemotherapy and radiation kill cells, they don't punch holes in the cells, right, like a cytotoxic T cell. What they do is you damage the DNA, and then when the cell tries to divide, it gets shunted into apoptosis. So these cells protect themselves from that. And oh, by the way, they protect themselves from cytotoxic T cells by down-regulating the RHLA-MHC complex. So they're hidden from the immune system. Now you should even be more terrified. We've now shown that there's stem cells with Max Wisha, who discovered cancer stem cells in solid tumors. These cells have all the markers of stem cells, which goes back to, I showed you how they repopulate a tumor. This is just a graph showing that in tissue culture, they're 3% of the population. You treat for 3 days, they're 90%. Take the stress away, they repopulate back to 3%, and now you have a resistant population that is actually cross-resistant with radiation. We know that these things are surviving therapy because they have a special kinesin, which is a motor for microtubules that allows them to cluster their centrosomes to allow them to undergo symmetric division and survive mitosis. So the conventional wisdom was these cells are all going to die because they can't divide properly, and they're going to form multipolar spindles. That's not true, and in fact we've now shown that all the giant cells that are polyploid giant cells and then the resistant progeny upregulate KIF-C1, and that protects them from death. So I now believe that tumor cell heterogeneity is not why we don't cure lethal prostate cancer or any cancer. I think that these cells, these polyploid giant cells with their high genomic content, are formed by the stress of a growing tumor. They can metastasize. They're actually, since they're quiescent, they're dormant when they hit the bone, and I've studied dormancy for 20 years, so this was a surprise to me. And then when we treat with radiation, we select them out, and then they repopulate with a resistant tumor. So I believe that therapeutic resistance is the result of this unrecognized subtype of cancer cells, these polyploid giant cancer cells, and we're trying to develop them now, recognizing them as a new target for cancer therapy, knowing that they're just a minority population. And I hope you enjoyed the movies, and I hope you're all scared. Thank you.
Basically, you've got these chemotherapy resistant and radiotherapy resistant cells. And they survive. And they'll survive in the lymph nodes, and they'll survive in the bone. And they've just been discovered. That's going to be our next target. But we don't have a way to target them at the moment. But they develop early on in the piece for patients with prostate cancer. They can spread out of the prostate really early, and they can be sitting adjacent to the prostate and some of the lymphatic tissue around it, maybe not in the lymph nodes. And the thought is that this is going to be one of the reasons why patients have biochemical relapse. And it's going to be one of the reasons why you can throw the kitchen sink at them and they're not going to do well, potentially, because they're going to have different levels of these cells around the place. It's an area for work. It's just been discovered. But it's going to be the direction that we're going to be working. Obviously, I'm a surgeon. It's going to be the area that the oncologist is going to be working in.
Are they in other cancers as well?
Yes.
Yeah. It's similar to what happens with pancreatic cancer, isn't it?
I don't know about pancreatic cancer,
Yeah.
but I have to assume yes. I'd have to assume.
The stem cells associated with pancreatic cancer transfer. I know they're doing some clinical trials at the moment on inhibitors to stop that happening.
Yeah, but it will be groundbreaking once it's through. I mean, it will shift cancer outcomes significantly. And if you can try to find a target for these cells, because at the moment they're resistant. Pardon? Except cutting them out and putting them in formalin. So, yes. Well, forever. Yeah. So the only way to avoid it is to get a prostate out early, so to speak.
You have a margin when you do the removal.
So
Yes.
So if you have a negative margin with the pathology on the removal, I mean, are those guys?
Those guys will still be there somewhere potentially, but not necessarily. But we know that we have patients who have a negative margin. We all have, who've had a negative margin, negative lymph nodes. They've got no detectable PSA. By all means, they're cured, but they're in remission. Patients like the term cure. They're in remission, and remission is really what we're talking about. And then it's why we do PSA testing. So we're doing PSA testing 3, 6, 12 monthly, whatever it happens to be, and then all of a sudden the PSA starts to go back. It's probably going to be that guy that's doing it. But we didn't know that. I mean, we knew that the PSA could come back. The patients had good, as best as we can offer that patient, they've had really good cancer control. And we know that the high-risk Gleason 9 patients might have derived benefit from some adjuvant radiotherapy. Maybe those guys at low-dose radiotherapy, if low volume of that, you can get them, but not at the moment. Do we know how to really target them? Do we know how to find them? But they will likely repopulate, and that's going to be the problem. What we might talk about it's getting a little bit later. It's scary stuff. It is scary stuff because it shows a lot of what we're doing. Now what we've got is...
Just one last question. Are they with everybody's cancer? Those big cells?
Those big... They will likely be in most of the cancers. I don't know enough about them. I only heard about them yesterday. They are likely to be in most of these cancers. They are likely to be sitting there dormant, though, for most individuals. But then they might not be. And it's when they're not that you have a problem. And so you don't view it as a defeatist attitude. I'd view them as a target for us to treat, like other things. I mean, this is not something for us to be scared of. It's something for us to respect. Just like we have fire. I mean, I'm scared of fire, but I'm not scared of fire. I know how to cook. You need to embrace it. You need to recognise it for what it is. You need to understand its danger, and then you need to know how to use it to your advantage. And I think that's how you should try and view this. But we just don't have the tools to do that yet. Continence is something that a lot of people will obviously have a lot to talk about, and it's a challenge post prostatectomy and potentially post radiotherapy, and it affects patients post androgen deprivation therapy as well. It's really a few interesting things that have been done, and there's a really nice presentation that was done by one of the guys from Queensland talking about the prevalence. Obviously we know it exists, and we know it exists in a lot more people at differing levels around the place, and radiation can affect it if post-surgery, lymph node dissection can affect it, and as I said, the androgen deprivation therapy can also start to bring it down. There's again another video that we'll see in a moment. What the ultrasound is showing is some of the muscles involved in continence, and these change post-surgery. So the muscles that we use primarily are going to be puborectalis, the urethral sphincter, and the Bulba Cavanosis muscle. So the Bulba Cavanosis muscle most men will be thinking of because it's the one that compresses the base of the penis and helps to ejaculate, but it also helps to compress passively and actively to an extent the base of the penis and give continence. But the problem that happens is that you're changing some of the angles of things post-surgery. The muscles are staying where they are, but you're changing the position of the bladder. And then the muscles that are nominally squeezing to give you continence are now potentially squeezing your bladder down and dispensing it through the slightly weakened pelvic floor. So your muscles are working against you. And that's why some targeted things are going to be helpful.
Functional tasks is also in voluntary activations of pelvic floor. And what we've been able to show, here's a cough. This is a man coughing again, capsicum spray. It just means that the man is coughing without any ability to voluntarily prepare. And what we can see is pinching of the urethra distally and then a contraction of the puborectalis after that. So these muscles having a really specific sequence of activation to maintain continence.
What I love is that they had a volunteer who took some capsicum spray in order to get a cough. The only way they get people to reliably cough with a probe there was to squirt capsicum spray at their face. It's the thing people do for science. Anyway, so you've got these muscles, however, with definite coughing going on. Each muscle has a definite and unique action on the urethra. I think there's a complex interaction in these functions. But they're changing post-radical prostatectomy. And the direction of some of these motions is different to what, as I said, to what it should be. And so after surgery, you remove the prostatic urethra and the smooth muscle that's within it, so you're automatically decreasing some of the passive effect that's going to be there. The bladder neck is going to have some interference with it. Potentially there's going to be irritation at the bladder lining that happens, and the bladder position is going to be different. And so what can happen is that you've got pressure coming down from above. So you've got excessive pressure from above, especially if patients have more weight around the belly. That's not going to be helpful for them. but you've got insufficient urethral pressure coming across to give closure. And as a consequence, patients can have urinary leakage.
The sphincter. There will also be variable interference with the bladder neck at the urethrovesical junction and smooth muscle there. There will be either none or some injury to the striated urethral sphincter or to its innervation. There may be irritation of the bladder, of course, and then an anatomical change of the orientation of these different structures, which may change the mechanics of contraction of muscle. For example, Pelvic rectalis may now squeeze the bladder rather than compressing the urethra. So then if someone's going to regain continence after prostatectomy, they need striated muscles to do something different. Tonic ongoing activation to compensate for the loss of smooth muscle. They need to have an enhanced capacity. If the striated sphincter is gone, then you've got these other muscles, the Pelvic rectalis and Bulba Cavanosis, that may be able to contribute. And you may also need to consider training the bladder as well. It also needs to be considered in this equation.
What the patient's got is suboptimal continence, and we're needing to potentially, with a physiotherapist, do some relaxation of the muscles that you previously thought you might have been needing to use, whereas contraction of different muscles. So we're needing to relearn some of the continence mechanism for some patients, not all patients, but for some patients. And that might be one of the reasons for suboptimal continence in a subset of men. The other thing that they're showing is going to be some of the changes that's happening with radiation after radical prostatectomy. And we certainly know that you get some fibrosis that's happening in the bladder, fibrosis that's happening inside the urethra itself, and the changes that happens with the decreasing elasticity and increasing rigidity that's going on mean that the bladder has less volume attached to it. It loses some of its capacity and also gets some abnormal contractions. You get some overactivity that you then previously might not have had, and so some medication might be helpful to try and get on top of that. There's also some long-term effects that can happen from radiation, so fecal incontinence can start to come through, but also the muscles themselves can start to be weakened progressively with time. So the anal sphincter can be a little bit weaker, and the pelvic, or the external striated sphincter can also start to get a little bit weaker around the urethra as well. We might need to start to consider the impact of these different radiation effects around the place. And the other thing that happens is there's going to be some inflammatory mediators that start to have effect. A lot of these are actually going to be similar to what happens for patients with injuries in other areas. And this is what I found really interesting. So the muscle, if they go doing some muscle biopsies and doing scans on it, the changes for these patients post-radiotherapy is quite similar to some people who have really bad low back injuries or low back pain, with some of the atrophy of the muscles and fatty infiltration that's coming through, changes in the connective tissue and the muscular fibres around them. The treatment for those patients is exercise. And again, that's going to be one of the reasons why we want to keep doing exercise of the pelvic floor for a lot of these individuals. And it can hopefully reduce some of the effects of radiation. So just like you can have some of this scarring that happens in the back, you certainly get scarring after radiotherapy, but exercise can prevent it and can hopefully reverse some of the fibrosis through some of the similar mechanisms that's happening with low back injuries as well. And so we want to keep on exercising patients. It's very important. So there's implications at the patient level, really, that you need to potentially be altering the pelvic floor exercises that you're doing, and also increasing the exercise that you're doing. And also, as you move forwards, keep on doing those exercises. A lot of patients will be having decreasing continence as they move forwards, whether they've had radiotherapy or otherwise. A lot of that's going to be because they've been less active with the pelvic floor exercise. They did it early on, they thought they were sorted, and they've been less vigilant, they've slipped. And so they need to keep it up. They need to keep it up. It's very important to keep it up. I'm sure it is. I'm sure it is. It's the same for women. And it feeds into this next slide about obesity and malignancy. So the prevalence of obesity amongst the US adults in 1990. Have a look at the black. The black is greater than 25%, so that's 1990. How much do you reckon we'll see of the black in 2017?
Too much.
How many states?
8%.
Oh, the whole country.
Don't know what that is. And Hawaii is going to be surfing. But so Hawaii has still gone up to 20 to 24. So So Hawaii's gone from less than 10% to jump up. Now, what happens to cancer? Body mass index and prostate cancer death. Clear correlation between obesity and bad cancer outcome. This is true for all malignancies, but we're a prostate cancer group. This is what happens with prostate cancer. Pelvic floor exercises aren't the only exercises that people need to be doing. They need to be doing all exercises. Calorie controlled diet to an extent, because that's obviously going to be an issue in the United States with sugar and a lot of things, but also lack of exercise is clearly going to be, input and output just don't match, and they need to be fixing that. So regular exercise and weight loss should be considered routine care. And really, I think I as a doctor, need to be proactive. And I certainly try to be for patients with a known malignancy to get them doing exercise. But we probably should do it for those men on active surveillance as well. We probably should really actually start to prescribe exercise for them. Because those patients will do better if they're exercising regularly. If they can decrease some of their weight around the belly, they're going to do better. We know that patients with regular exercise have lower levels of anxiety, lower levels of depression. Some of the cognitive effects that can happen from androgen deprivation therapy are going to be less. Their social interaction is going to be greater, especially if they're doing group exercises. Is going to be better all round for those individuals. So not socially, emotionally, and also from a cancer control perspective, exercise is going to be the key.
Any specific exercise? I know that's the thing these days.
It's all exercise.
Gentle weight. You want to be doing something with a little bit of weight. A bit of resistance. That's what the weight is. So in general, for people as they're getting older, they want to have some degree of resistance exercise. So not high weights, just low weights. So that they're putting a bit of strain on the muscle. You want something from a cardiovascular perspective. Obviously, different people have different levels of cardiovascular ability, but most individuals should be able to do some gentle isometric exercise. Most individuals. Even if you're just doing some squats at home, even if you're doing some sit-ups at home, you can use your body weight as a weight. I mean, you don't need to buy weights. You can use your body weight to go doing it.
Would HIIT exercises be any more beneficial than anything?
Look, the high impact, high intensity exercises, the HIIT exercises, will be great, but they're difficult for a lot of individuals to do. They're certainly a good way of burning a lot of calories in a very limited amount of time. A lot of the older patients aren't going to be able to have the cardiac endurance for that. They just don't like getting their heart rates up that high. But certainly if you can do it, then yeah, go for it. So if we look at some of the medical oncology, so medical oncologists are coming earlier in the piece. They're blending the roles of the clinicians. So the treatment options that we had in 2009 for patients really were sort of like this, where they had no metastatic disease. They had METs and they got some docetaxel, and they had a mitoxantrone or some docetaxel if they were really symptomatic later on in the piece. 10 years later, and that's what we're looking at the moment. The landscape in medical oncology has changed significantly. I mean, it really has changed really significantly. So it's changing rapidly. People are getting longer survival as a consequence. Charted data has come out showing the addition of androgen deprivation, the docetaxel to androgen deprivation therapy significantly improves length of life. The Enzamet trial has just been published. So the Enzamet trial, I don't know if anyone here has been on it, but we've been a centre with patients here at the SAN for a while, with a lot of people going through it. It's been a multi-site study led by Ian Davis, who's an oncologist from Australia. And this gives about an 8% survival advantage at 3 years, which is really quite significant for a lot of individuals to get them there. So if you look at the curves as we go along, that's what we're seeing for patients with a normal standard of care at the bottom. Normal standard of care at the bottom versus those with enzalutamide at the top. The curves are only continuing to diverge further and further. And so there, we'll leave it an upside. There's a definite upside there. So that's 4 years out with ongoing improvement in survival. So this is for patients early in the disease process. So previously Enzamet was only given later. This is going to be people with really early, as soon as they're starting androgen deprivation therapy, we will hopefully be able to start to give the enzalutamide at the moment. It's just too expensive, but that will shift. There's a PBS rebate for those who've got advanced disease and castrate resistance, but we'd like to start to offer it earlier, and that will shift, yeah, once the funding comes through. But they needed the paper to support that. Okay, thank you very much. Pleasure.